You're watching once again a YouTube video presentation of the University of Wyoming Center on Aging. I'm Scott Veach. I'm your host, and in this series we'll be discussing topics of interest for those who are caring for loved ones with dementia. We invite you to subscribe to the channel, and we hope that you'll hit that thumbs up like button. Both of those actions help our channel to grow and reach more people. And if you'll hit that notification bell, you'll be notified each time we upload a new video. Thanks so much for being with us. Our guest today is Theresa Robinett. She is an occupational therapist who works in Casper, Wyoming. She also teaches in the occupational therapy program at Casper College. We're so glad to have you with us. Thank you, Theresa. You know, one of the things that I wanted to start with today is that in the presentation you gave to our group back in June, you talked all about building caregiver confidence, which kind of makes me think that maybe that's an issue for caregivers, that it may seem a little overwhelmed by the prospect of being a caregiver. Is that the case?
I think so. What I do here professionally at the college is I teach occupational therapy assistants. So essentially folks that are going to go out and be professional caregivers, professionals in that. And I see that from my students too, coming in and having all these good intentions and doing really good things, but then still questioning themselves. And I feel like sometimes folks that are drawn to this or put in this position, they are extra hard on themselves also. So many times caregivers, so many times folks, like, you're doing a really good job. Some things are going to go good. Some things aren't going to go good, but we can't just, keep repeating those things and making those changes. And I think just sometimes folks that when they're in that position and doing the hard work of caregiving for somebody with needs and challenges, you need maybe a little bit more information or a little reaffirmation that you are doing good, or maybe change a few things, and that's fine too. I remember being a new practitioner, I was so scared and so nervous as a professional that they would say, if I changed something or if I did something different, they would say, oh my gosh, you must have not known what you were doing to begin with. And I had this kind of awakening with another colleague, and they said, no, changing is what makes what we do skilled. Changing and being like, this isn't working, this is what we need to do differently. That's really a good thing. And that's what I think for our caregivers too, is sometimes maybe they feel worried, they feel scared, these different things. Oh, I don't want to change because this is the way we've always done it. Well, we know with dementia, one day from the next isn't going to be the same. So just making sure our caregivers are giving themselves some grace. They're not holding themselves to this same kind of challenge day to day, and just knowing that some days are going to go really good and things are going to click and other days are not. And that's okay. As long as we just kind of keep moving and keep trying different things.
Let's talk about occupational therapy, which is your area of practice and expertise. How does that fit in with the caregiver?
Well, occupational therapy, I hate to say it, but we're probably more of the obscure of the rehab professionals. We've actually been around for over 100 years, but we're really bad about talking about what we do. And where occupational therapy comes from is at the turn of the century, around World War I and things like this. They would have, a rest cure was what a lot of physicians would prescribe, and folks needed rest. Well, there were physicians at the time that believed also people need occupation. They need engagement. They need activity. They need a meaning. They need something that gets them up every day. And so they started prescribing what they would call like a work cure, or using meaningful, purposeful, designed occupations. And over 100 years, our profession has really evolved. And where we come into play now, especially with folks with dementia, individuals, is occupational therapists now, probably starting in about the late 70s into the 80s, we really started working with older adults. And then as we know, as dementia has changed and become more prevalent, become more of an issue, occupational therapists provide services to individuals with dementia, because I think we can provide a unique way of looking at things. We can kind of be problem solvers. And my big thing is I want my clients engaged and in something that makes sense for them, something that works for them and at that highest level of function, because, just not doing is not well either. So looking at, okay, how can I make changes? How can I make the environment work? How can I help support caregivers so an individual can function and do occupations that are meaningful to them, but work within their abilities, if that makes sense at all.
Right. So what does the occupational therapist do?
So an occupational therapist will Typically, we use a physician referral. So a primary care physician can make a referral. Occupational therapists work home health, acute care hospitals, skilled nursing facilities, a lot of different places along the parameter and the continuum of care. And so we'll get a referral from a physician. A lot of times that referral to me will say eval and treat. So the evaluation, I'll sit down, and those could be 60 to 80 minutes typically. And I'll run through a whole evaluation of physical, sensory motor, some basic, maybe some psychosocial skills, and then even looking at some pieces of cognition as well too. And I'll kind of take all those different pieces and I'll ask the client then or the caregiver, what's important to you? What are things that you want to see them do in a day? What are things that matter to them and are important so that they can essentially have the highest quality of life that they can right now? And I'll put on my problem solving hat and I'll look at different ways that I can either change the environment, I can help the caregiver, I can work on different things with the client so that they can do those things that matter to them.
How do you evaluate where the individual is and what level or what kind of services they need? Is there one way of measuring that?
That's a great question. So there's a lot of different ways. There's a lot of different ways that professionals and I even teach my students that too, find theories, find frames of references, find these approaches that make the most sense to you. And so there's a lot of different things that we can do from, taking a very biomechanical approach and looking at how the body moves, to some of the cognitive pieces. And the cognitive model that really clicks for me personally and as a professional, and there's going to be some OTs out there that are not going to use this model, but it's a pretty popular one and it's a pretty prevalent one. It's been around for a long time, and that's the Allen's cognitive disabilities model. I remember coming out when I was in OT school, we kind of talked about it and they were like, okay, here's another model, here's another tool in your toolbox. And I was like, okay, that's cool. And I kind of put it aside. And then I started working skilled nursing facility as a new practitioner. And I was just really struggling. I was really struggling finding a way. I had a lot of folks I was working with dementia, and folks asking me questions. And I felt like I was struggling as a practitioner to really justify and like back up some of my reasoning and some of my decisions. And so I went on and I took some deeper classes and dug deeper into the Allen's cognitive model that I talked about, and I'll talk about here a little bit briefly. And for me, and the way that my mind works and brain works, it really clicks for me. So just to give kind of a quick summary, the Allen's model was developed by an occupational therapist by the name of Claudia Allen. And it wasn't designed necessarily for folks with dementia or anything like that, but actually in mental health. She started working out in inpatient psychiatric. But her theory is that anytime somebody has a chronic health condition, they're going to experience changes in their cognition. And I think that holds water. I really do believe it. I mean, even if somebody's sick, if somebody's dehydrated, if they have an infection, our cognition changes. It's very fluid. It doesn't stay the same. And then over years and years and years, folks started applying the Allen's model to individuals with dementia, and it's held up. There's a lot of research behind it. And actually, I think probably in the past 10 years or so, the Allen's model's kind of had a rebirth in popularity because of the folks that we see with dementia. And it's a difficult thing trying to kind of understand where it is that they function, where they're currently functioning, and then trying to help make that world around them. Because I know as an OT practitioner, I cannot affect or change what's going on in the brain, the neuroscience, the chemicals, the atrophy that's happening due to the chronic and progressive nature of Alzheimer's. But I do know as a practitioner, maybe I could change some things in the environment. Maybe I could move some things. Maybe I could help caregivers. Maybe the way that I speak to the individual would help. And so I know that if I change some things in the environment, that could help them function better. And the Allen's model is a really well-researched and has a battery of assessments, a battery of tools that kind of help give me some insight into where my client is at that moment in time.
You're watching once again. It is, excuse me, it is a YouTube video presentation of the University of Wyoming Center on Aging. We invite you to subscribe to the channel and hit that thumbs up like button. Both of those actions will help our channel to grow and reach more people. And also, if you'll tap that notification bell, you'll be alerted every time we upload a new video. A moment ago, Theresa, you talked about the battery of tests with the Allen model. What kind of tests?
Oh, there's quite a few, because there's a lot of different things, a lot of different folks in different stages of cognition. The primary one, and if somebody gets an OT referral that you might see, and it's this assessment that you're kind of wondering, what are they doing? This just looks kind of strange and interesting. It's a leather lacing task. And I actually have it right here on my desk because I just keep it handy. I don't know what my deal is. But
Kind of a manual dexterity type thing?
It helps sensory. So it's a combination of sensory motor. So what I'll tell my clients is, it helps me understand how well you can pay attention and follow directions. So yeah, so there is a fine motor component. There is a smaller version of this. I don't even use it just because I'm not too much worried about some of the fine motor controls and things like that. Again, it's for cognition, but they do have the larger one to help with vision. So when folks have low vision, these are easier to see and things like that. But what we like about this is so many times in dementia or cognitive changes, folks can kind of mask some of these changes by engaging in activities, ADLs, things that they've done every day. So getting up, doing their basic routines in their home, maybe the loved one or caregivers or family, they're like, gosh, I haven't noticed these changes because mom or dad, they've been doing really good. They're still just doing things in their home. But what we like about with the Allen's model is kind of focus on arts and crafts, focus on doing the leather lacing, is the unfamiliar. The fact that it could be something kind of out of the norm, out of something that they don't necessarily would do typically. And so it can give me a little bit more insight into that ability to follow directions, keep track of things, some of that short-term working memory. So it can give me a lot of information, and it's pretty quick. It's not a timed assessment. So however long it takes the individual to do it, I just let them do it. I also will follow a very strict script that I won't veer from, because then if you veer from the script, then it's not a standardized assessment. So if you as a caregiver, you're kind of wondering, what's this person doing? They're not talking. They won't talk to me. That's what they're doing. They're providing a standardized assessment and really watching. So I'm observing the individual. I'm really watching what it is they're doing, and I'm keeping track of that, because then that helps me give them a score on the Allen's cognitive levels.
Is it difficult to get the individual to cooperate? Sometimes they really just don't want to do it, or things like that?
Yeah, definitely. And if somebody refuses it, then that's 100% their right. And we have some different assessments out there that are just observation based, where I could watch them engaging in a task. We have some different assessments that I can do at that point too. Also too, sometimes, because the Allen's model believes that if a task is too hard, someone will dismiss it. And if it's too easy, they'll dismiss it. And so if somebody kind of attempts it, and I notice maybe it's more of a cognitive issue or confusion or things like that, that could be then how they score on the assessment. And I'll do some other assessments to help kind of back that up. But that could be an indicator of maybe this is too complex, and that could help me have an understanding of where they are.
What other things are involved then in the assessment?
So the leather lacing is one type of assessment. There's a cognitive checklist I can do that's observation based. There's a cognitive performance test that we do, and it uses different activities of daily living to assess it. So, how well an individual can manage. It's kind of like a mock medication, where they are given instructions and they have to organize and read prescription medications. I have a shopping task where I give them a certain amount of money and they have to problem solve and do some shopping tasks. Even cooking, we do like a simple toast making, hand washing, ADLs, and then there's certain parameters that I look for. And then within the Allen's model, there's also the Allen's diagnostic modules, which are a variety of different arts and crafts activities. And then based on that kind of gives me an idea of where they are in cognition too. So that could be a whole, that we actually spend a huge unit here with my OTA students just hitting these pieces, because it is very extensive.
I was going to ask you, how long does it take to do an assessment? Because it sounds like it could be pretty involved.
It could be. It depends. Usually if I'm going to do like a larger assessment, 60 to 80 minutes, and then maybe might have to stop and pick back up later. But yeah, if I'm going to do a big assessment, that's usually what I would schedule.
So you finish the assessment, then what happens? You rank them on the scale, and what happens to the information?
Then I can use that information with evidence from the Allen's model, and it kind of helps me have an understanding of what to expect. Like we see with dementia, changes in an individual's vision, changes in problem solving, things like this. And a lot of times when I was working full time, I would really communicate with other folks that were familiar with the Allen's model. One of the greatest things I liked in my before I came here to the college is I worked with a physical therapist who had also done a training with me. And I would visit with him and he would say, oh, okay, well, maybe it's not appropriate to start them on a front wheeled walker, or maybe it's not appropriate, maybe looking at doing mobility in the home a different way. So then that's when we really start putting our problem solving on, when I have that information and can start writing goals and then creating interventions to meet those goals that make sense. Because the thing is with dementia, it's chronic and progressive. So we need to be really realistic of where we're heading, what's going to be realistic, instead of trying to go in a direction that might not really be what they need.
For the caregiver out there who's watching this video right now, what would they have to do to have their loved one assessed with the Allen model? And is it available everywhere, or is it pretty standardized? What would they have to do?
Well, I think the big thing is to first start having a conversation with their primary care physician, letting them know, hey, this is something I stumbled across. Could I get an OT eval and referral? And then once they write that referral for OT, visit with the folks, call that home health agency and say, hey, this is a model I'm just interested in. Are your therapists familiar with it? And some folks, more than likely, they did learn about it in school. I know like my OTA students, which a lot of my OTAs go out and cover pretty much the state of Wyoming. A lot of our students are homegrown, home raised. They come here to Casper. They either stay here in Casper or they go other places here in the state. So I know they're familiar with it. But that's not to say that all OTs have to practice this model. There's going to be some OTs out there that say, oh, that's an older model. That one doesn't make sense. There are going to be some folks out there that really do use it. And I think it's just worth having that conversation. And even if they don't use the model, I think still asking that OT and saying, okay, so what are we doing? How do we know where their level is? How do we kind of know where their function is? And more than likely that OT has a different assessment or a different process that works for them, that's still going to get results and still going to be really good and really beneficial. But I think it's just worth, as the caregiver, again, kind of building that caregiver confidence of saying, here's something I learned about. Would this be beneficial for my loved one? And maybe it would be. I know as a practitioner, maybe somebody brought that in and I said, hey, yeah, let's give it a try. It could be a good fit.
So you get the assessment, the caregiver gets the results, and the individual also, but the caregiver gets the results. Then what happens? Turn them back over to the primary care physician, or where do we go from there?
Well, it depends on a lot of different things. It depends on their condition. It depends on what really the goals are. Me as the OT or an OTA might work with them for several weeks, working towards those goals, seeing if we make some changes and kind of help them support whatever it is they're doing. Say if we're doing home health or wanting to keep them in the home or return them to the home, the OT will do, we'll work with the caregivers and say, here, try this technique. Try maybe transferring them this way, or try communicating them this way when it's time to go to the bathroom or use the toilet or use the shower or things like that. And we'll go through that. And yeah, the OT then will have to write at a certain interval a reevaluation that will be sent back to that primary care physician for them to certify. And then kind of when we feel like we've reached as much progress as we're going to, we might visit about looking at a discharge. But once somebody comes off therapy, they can also go back to therapy at some point. It's not just this fixed thing. Somebody might pick up therapy here and there, stop for a while, maybe resume again if an individual maybe has a rehospitalization, has a change, has a fall. It's definitely not a fixed scenario, if that makes sense.
You've been watching once again a YouTube video presentation of the University of Wyoming Center on Aging. We invite you to subscribe to our channel. We hope that you'll hit that thumbs up like button. Those actions will help our channel to grow and reach more people. And if you'll tap that notification bell, you'll be notified automatically each time we upload a new video. I'm Scott Veach. Thanks so much for being with us. We'll see you again next time.